Thank you guys for coming in. We're gonna talk a little bit today. Actually, the whole reason for doing this lecture was in direct response to the lecture I did before on COPD update, specifically with the GOLD guidelines and the updates that they had for 2017. If you'll remember, we talked about the fact that the GOLD has actually changed from just talking about category of disease to talking about class of severity and then category. They took exacerbations rather than making it a possible way to categorize COPD and made it a very important aspect of how we categorize COPD. And then they took out the severity component because severity was kind of getting lost in the mix. Again, the whole reason for classification of COPD ultimately comes down to how are we going to treat the patient? And really, that's all that anytime we classify something or name something anymore, our goal is not necessarily to give recognition to someone as it used to be, as much as it is to try to create a name that tells you how best to pursue treatment and to take care of patients. So this lecture is one actually that I had the pleasure of giving at a state conference. I was asked to give a lecture on COPD medications and updates in COPD medications. But really something that's been near and dear to my heart is something that you guys talked about on Tuesday, and that was health literacy. Health literacy is something that I think we all deal with on a day-to-day basis, but a lot of times we miss. And you guys have already heard a lecture on that, so we're not going to bemoan that point. We're going to hit on it a little bit. What I want you guys to be able to do right now is I want you at the end of this to be able to define what health literacy actually means. That should be easy since you had an entire lecture on it. I want you to identify barriers to proper medication use, and then I want you to be able to demonstrate appropriate techniques for certain medications. And really what we're talking about are medications that we use for the treatment of chronic obstructive pulmonary disease. Now, we're going to concentrate on non-nebulized medications. We'll talk a little bit about nebulizers, the different types of nebulizers that are out there, but that's more from an inpatient standpoint. Most of the time, we're going to be giving those in a nebulized fashion. On an outpatient, we're talking about chronic management. So what is health literacy? What do you guys think? Give me some definitions. What do you think health literacy is? It's what the patient understands about their condition, okay? What else? The ability to understand instructions given to you by your doctor, okay. Because that goes a little bit beyond just their disease condition. That goes maybe a little bit more to what you do with that information or how that information is portrayed. Good, what else? Yeah.
The ability to maybe convey medical information so that both you and the patient can make an educational decision about treatment.
Okay. So the ability to convey information in such a way that you and your patient can develop a treatment or a plan of care. Great. So the definition, health literacy really is the degree to which individuals have the capacity to obtain, which we talked about, process, develop a plan of care, understand basic health information and services needed to make appropriate health decisions. Ultimately is, do patients understand what you're talking about? Okay. Do they know what you're talking about their disease process, about their treatment, about what your plan of care is? The World Health Organization, there are multiple different articles about health literacy that have come out. It is becoming more and more of a mainstay in what we do from a education standpoint when we're talking to residents and we're talking to students. We want us to start thinking about how we interact with patients. The previous ideas of what it was like to be a physician maybe aren't quite what we want them to be anymore. You know, the idea of you just telling a patient what to do and they do it without any question, that's kind of out there. The other thing is, we as physicians and students, we spend 4 years in medical school learning a completely different language, right? I mean, really, that's what you're doing. The concepts of how things work together, they're not overly difficult, but using the right language can sometimes be very difficult. The best part about that is then you have to go out and talk to people where you cannot use that language. Your job is to relate what you've learned in medical school to people who don't have any knowledge along those lines. So the best example I have of this, and some of you guys have heard me say this because I personally love it, is this word right there. Okay, if I ask you guys in this room, what does this word mean? You got the pressures. All right. What does this word mean? Matt, what does this word mean? No, to you. What does it mean? You have standing vasoconstriction. Wow, he's going for the physiology. Garrett, what does this mean? You have high blood pressure. Thank you. Matt's going for physiology. Yes, it means you have high blood pressure, right? Now, if you imagine that you have no idea what this word means, which actually a very large percentage of your patients have no idea what this word means. In fact, Mayo Clinic did a study and they showed that over 70% of the people that came into their offices had no idea what the term hypertension meant. You know what's interesting? Most of them had hypertension. A good portion of those people knew they had hypertension and they didn't know what it was. Now, if you had to guess, and they went on with this and they asked them, what does this mean? And they said, I don't know. Let's go back to grade school and break it down, right? It breaks down into two parts. One is hyper. Now, what does hyper mean, Ken? For those of you who can't see, he's chewing on food and aggressively moving his hands. Yeah. Exaggerated. What does it mean to you, John? It means too much. You guys are way too good. What does it mean to you? High. Okay. What does it mean to you? Overactive. Now, see, now that's what I'm thinking. Because you know what these guys hear? Hyperactive attention deficit disorder, right? Hyper. I have a kid who's hyper. That's what they think, okay? Now we've got this other word, tension. Now what does tension mean? What does tension mean? It means you're really tense. Okay, so we're gonna mix, it means you're really tense. You just used the word in the definition. You can't do that. What is it? What is it? Well, that's true. Patients would use the word in the definition. All right. Well, Azhar, now you have to tell me, what does tension mean? Stress. Tension means stress. So you have two words that you've broken down. So what does hypertension mean to your patient? It means stress. It means anxiety. As a matter of fact, most of them thought that hypertension meant that they had anxiety disorder. Okay? That is health literacy. How are we going to possibly talk to them about their medications? The interesting thing was they said, oh, that pill's for my blood pressure. And the doctor said, yeah, it's for treating your hypertension. And they said, no, I don't take any medicines for my hypertension. Okay? In this person's mind, they had completely separated the term hypertension. And that's a word that we use all the time. So that's what health literacy is in the grand scheme of things. A study was done that actually looked at what they did was they actually had physicians who were trained in health literacy go in and talk to patients. And then just in a normal encounter, this is not simulated, this was normal encounters. What they did, went back in and they fed, what they then did is go back, watch them, and specifically looked for the use of jargon or unclarified jargon. 81% of physicians used it. Now, they weren't looking for understanding. All they were looking for were terminology that we use in the medical field that is not used regularly outside of the medical field. 37% had jargon when they gave general recommendations to the patient. meaning that you're using language the patient doesn't understand to explain to them what they have to do about their medical condition. And then 29% used it during the education about what their disease process was or how they were going to treat them. So to say we don't do it is wrong. And unless you're very conscious of it, you're going to miss it. All right. Now we're going to talk about in COPD. And originally, when I was asked to give this lecture, I was asked to talk about the new medications that were on the market. Now, let's be honest. In COPD, there really isn't that many new medications. There's a lot of new names, but ultimately, there's 3 classes of drugs. There's beta agonists, okay? That affects the sympathetic nervous system. There's anticholinergics, which do the parasympathetic nervous system. And then we have anti-inflammatory medications, which include steroids. And you could make the argument include some oral medications, including Dalaresp, because it affects the immunological response within the lung itself. You basically have 3 different classes of medications. All these new fancy names that are coming out simply are ways of organizing that. Instead of having 1 drug, now you have 2. And even recently, within the last 6 months, we now have a combination of all 3 in one whose name is, wait for it, Trelegy. They can't call it Trilogy because Trilogy's a ventilator. So they changed the I to an E to make it just that much more confusing, and it's called Trelegy. Okay. Now we'll talk more about, the different devices and whatnot. But when it comes to COPD, I think the more important thing that has changed over the years, and the thing that's going to have the biggest impact on you and how you take care of patients on a day-to-day basis, has nothing to do with the medications. It has everything to do with the devices that those medications come in. Because there is no other disease process that we take care of on an outpatient basis, on a regular basis, that uses more devices than COPD. Now, we're getting close to that with diabetes. And back when we had inhaled insulin, that created all sorts of issues. But right now, nothing compares to the plethora of different devices used in COPD. It was my goal today to use plethora in my lecture, and I just accomplished that. Thank you, Dr. Greider. I'm happy about that. Say what? Explain that jargon to me. Watch the Three Amigos. All right. Devices everywhere. There are a bajillion of them. And most of you guys have seen a lot of these up here in the, well, if you're looking at it, the upper left is your HFA, the standard, the one that's been around for a long time. You've got your Ellipta device. You've got your spacer over here on the right. You've got your Handihaler from your Spiriva. You've got the nice Respimat inhaler right in the middle. And we'll talk a little bit about these different devices. But what I want to show you is I want to actually show, how many of you guys have sat down and read the instructions on any of these devices? Actually read them? Yeah, some of you. Why? Because you couldn't figure it out, or because you wanted to make sure you knew exactly how to take care of it for your patients, or so you could tell your patients? Probably a little bit of both, right? You're like, I have no idea how this thing works. If you can't figure it out, chances are your patient's going to have a difficult time with it anyway. All right, so let's talk a little bit about history. COPD as a disease process actually is not, it's been around obviously forever, okay? Damage to the lung that's irreversible is essentially what you have with COPD. That goes back to the origin of the lungs, okay? Things get in there that aren't supposed to be there, generates an inflammatory response. Inflammatory response causes the damage that inflammatory response causes. Therefore, you have lung disease. Asthma has been much more well defined than what exactly COPD is, and the causes and effects of those have definitely been looked at. Now, for inhalers, the idea of utilizing an inhaled medication for the treatment of COPD has made sense from the get-go. Well, if you have problems with breathing, inhale in a medication. Now, what you inhaled, that has changed a lot over the years, whether that be cocaine mixed with water or whether that be some other form of, mixture that a guy in a closet back behind the soda shop mixed up. But The different types of inhalers that we had really started with nebulizers. And I think that makes perfect sense. The compressed air nebulizer has been around for a really long time. In fact, this was way back in the 1930s. Right up here, you can kind of see up in the upper left, you can see a guy who has a mask, and he's actually got a compressive pump that's pushing air in and aerosolizing a liquid. Okay, that's what those nebulizers were like. What we actually have is a little bit different. We have ultrasonic nebulizers that utilize sound waves to help dispense the medication, and that's what we utilize now. We can thank the 1960s for that. But the first Medihaler, the first device that gave out a standard dose of medication, did not come out until the late 1950s or 1956, I guess mid-1950s. What medication did they use in that device? Racemic epinephrine, okay, or epinephrine. They used epinephrine, and in fact, we had that for how many years? It was over the counter until when? That's a question. There you go. That's my question for right now. That's my trivia question. Feel free to chime in if you are outside of this room, if you know when Primatene Mist went off the market. Dr. Greider still has one in his medicine cabinet. That does not surprise me a bit. Close. So by close, I mean you were within a decade. 2011. And the reason I know that is because when I was training, we had patients who would come in who still had a Primatene Mist inhaler. And why was it taken off the market? Anybody? What? Because it's epinephrine? No, it's just, what else? Yeah. No, patent renewal. Good question. Always money. Go to money. No, not. It was the ozone layer. The reason it was taken off was because it was a CFC, and the company that made it was not going to develop a different propulsion. So yes, in an effort to be green, we took Primatene Mist off the market, and we prevented many heart attacks as a direct result of that. One of my favorite patients who came in was a little guy. He was in his 70s. He had a terrible heart, but he also had bad COPD. And he came in and he said, for the last 4 days, I've been using my inhaler and it really hasn't been doing anything to me. And I said, really? His blood pressure was 190 over 120. And I said, what's your inhaler? And he pulls out a Primatene Mist inhaler. I was like, holy crap. I had another patient tell me that that was their allergy medication, was their Primatene Mist inhaler. So people have different views of what these inhalers are for, and it really comes down to that. But anyway, the MDI that came out was used for epinephrine. And then we have lots of different other things that came out. Spin inhalers, breath-actuated MDIs, that's where you actually generate a breath that stimulates the release of the medication. Kind of a neat idea. Dishalers, Rotodisc. This is actually pre-Advair. These inhalers actually had a cap that came off and the inside actually spun, but they were kind of the early markers for the development of the Advair Diskus. Autohalers, which are, again, the breath-activated MDIs, got better. Diskus, and then the Novalizer, which is what we see with Tudorza, came after that. Now, if we extend this out, we have the new Ellipta device, which is kind of a culmination of a lot of different factors. But let's talk about these different types of devices, because I think it's important to understand the limitations that they have and also the benefits that they have. We'll start with metered dose inhalers, because this is the inhaler that everybody has seen. This is the inhaler that everybody's aware of. Now, what you see in the middle here is, believe it or not, this is the instructions for the use of this medication. Okay, so if you want to explain to a patient how to use this, this is what you have to talk to them. Everything from take the cap off, shake the inhaler, Seal lips around the mouthpiece while opening with your teeth. Start to breathe in slowly through the mouth, then activate the inhaler while continuing to breathe in. Breathe in slowly over at least 5 seconds until lungs are full. Hold your breath as long as you are comfortably can, and then relax. Replace the cap. Check the dose counter on your inhaler regularly. If it is 1, you need so you know when a new one is a good time, and always keep a spare inhaler. You have to give them all of that information, including take the cap off and put the cap back on. So I'm going to show these guys here, for those of you guys who are out there. You've seen these inhalers before, and I want to show you a couple things that have become revolutionary about this device. Okay, number one is we had a big change because of the ozone layer back in 2011, and that was that we got rid of CFCs as propulsion agents, and we have gone to using HFAs. Now, there was a lot of speculation that what this meant was we were going to have a lot worse control of our asthma. And the main reason is because of what you can see in this picture. Now, this picture doesn't do it justice. If you had an old CFC inhaler and you stood 4 feet away from a wall and you sprayed it at that wall, you'd make a wet spot on that wall, because of the power of the propulsion in that device. With HFAs, you don't get that. So the thought was, we're decreasing the rate at which medication enters into the lungs, thereby we're going to get in the way of medications. Well, 2 things happened. One, when they went to the HFA, it slowed down the rate to which medication was released, but actually, medication availability was felt to be pretty equal, if not better. Because what is one of the biggest challenges with doing an HFA or doing an MDI? Timing it, hitting the back of the throat, taking it, losing it. All of these are important ones, yes. But actually, if you've got a person and you hand them an MDI and you say, hey, I want you to use this, one of the biggest struggles they're going to have is that they're going to spray their tongue, they're going to spray the top of their mouth, they're going to choke on it before they ever get to breathing in. And what they found with HFAs, by decreasing the rate and decreasing the force in which, they weren't causing whiplash with their CFC device, that actually they were able to take in that deeper breath a little bit easier and help to rectify that. Now, we'd also figured out that using a spacer helped a lot. Certainly a lot of the inhaled corticosteroids for asthma, and even with the albuterol, there is indication for spacer usage, especially in kids, because you have to be able to time your inspiration with the activation of the medication. Now, that does require several things. What are complications or reasons why this device might be challenging to use? i.e., how many different ways can you screw this up? There are many. Spray your skin. That's a good way of doing it. It looks like my perfume or cologne, let's be honest. It's probably the guys. One of the biggest innovations that ever came with this device was actually this, the fact that the cap was attached. Why do you think that was important? Because they lose it. Then what happens? Do they throw away the inhaler? No. They put it in their coat jacket, or they put it into their purse. And then what gets down inside of there? Dog hair, cockroach poop, whatever, right? Every allergen known to man, and suddenly they're inoculating themselves every time they take a dose. So the idea of just adding this little thing here to a cap, this is an innovation. This is engineering at its best. The other thing that this has that other earlier ones did not have is a counter, because the counter, previously you would just use it and 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 use it until when you push down, nothing came out. But what they found was the amount of medication was gone way before the propulsion. So you are actually not getting any medication despite the fact that you were using the propulsion, okay? So the cap, the counter, these are really important things to help use this device appropriately. Other things, you have to be able to push down, okay? There's actually a certain amount of force that's associated with the use of this. Now, that may not be a big deal if you have a young, healthy person with asthma, but if you have an older patient who has COPD, that can become a very big challenge. Just handing them this device and saying, hey, use this, can be a big, big issue. And the reason why this device is important is because literally every single class of medication comes in an MDI of some variety, okay? And they're going to be around forever because they're easy to use, they're easy to carry around, but, so what? And they're cheap to make, okay? Now, the HFA did cost about 10 times the cost of the CFC devices, but that's a whole other thing. It's definitely getting better than it was. Dr. Greider and I can definitely remember when they first made that switch over and people were able to get an albuterol inhaler for $2, who are now paying $40 and $50 per their inhalers. They were not happy, especially my lady who would take a puff off of her inhaler and then take a puff on her cigarette because it helped her to get more nicotine every time she breathed in. Genius, yes. All right, so MDIs, they have their complications. Part of it is pushing down on that, timing it just right so you can get the medication. That becomes a challenge. If you've got, also, when we would educate people with MDIs, we had to tell them, you have to start breathing in before you activate the device. Otherwise, you would hit your tongue, you'd hit the upper part of your mouth, and you'd never get your medication into your lungs, okay? So we had to teach them, start breathing in first and then activate the device. It goes in really fast. If they don't do it wrong, great. They can use a spacer sometimes. Interestingly enough, ICS LABA medications do not have any indication with spacers. It's never been studied. That does not mean it doesn't work. It's simply never been studied, okay? So really right now, albuterol and Combivent were the only two that actually have indication for the use of it with a spacer. All right, enters the Diskus. From the MDI, we kind of get the Diskus, and the Diskus won a lot of awards actually from an engineering standpoint because of the simplicity of use. Now, you guys have seen Diskus before because a lot of you have seen Advair or Ceravent, which was the brand that really brought this to market. Now, the Diskus has a lot of benefits to it. Number one, it doesn't have a propulsion. Now, the fact that it doesn't have a propulsion means that timing isn't quite the factor there. It was also nice that the cap or the lid was built into the actual device. Again, of course, you have to close it, which if you think about all the ways people can mess this up, that is one of them. So as you open it, you will notice on the side of this device, sorry, you guys can see it in the picture, there's actually a button on the side. Now, when we first gave this to these patients, again, we're trying to talk about how people can screw this up because we want to think like a patient when we give them these meds. We would think, oh, this is self-explanatory. You open it up, you push it back. That opens up the window. You suck it in, you close it up, you're done. But how many different ways can a patient screw that up? Well, if you want to know, just hand it to a patient and say, open this. They will try to rip off this outer shell, okay? Rather than just try something else, they will do it as hard as they can. I watched a guy who was a farmer put his fingernails underneath and rip back and tear the plastic. Thank God he didn't hurt himself in the process. He did destroy the sample, and we had to get him a new one. I said, no, let me show you how this works. So just opening this device does take a little bit of work. Put your thumb in the holder and open it. Now here's the thing. You actually have to open it all the way to the click, because if you don't, it can move on you, and sometimes this thing can smack you in the face. But when you open this up, people also saw this button on the side. Well, what had they used before this? an MDI. And what happened when you push down on an MDI? You got a full face full of medicine. So what they felt was, when I push this button, medicine's going to come out. Okay? So what they would do is put their mouth on here, push down on the button, and breathe in as they push the button in. Now, if you do that, you actually you're not using the appropriate way the medication was designed, but also you initiate inspiration. COPD patients struggle with the volume of inspiration they have. Now, COPD is an air trapping issue. Their lungs get quite full, so they don't have a lot of volume to actually breathe with. If they start breathing too early with some of these medications, that's a problem. This is a powdered medication, and so they have to use their inspiratory effort to actually get the medication. That's one of the biggest problems we have with patients and all of the powdered inhaled devices. The other thing is, the window inside of here is actually pretty small. You're like sucking through a straw, which also requires effort and energy, which may or may not be challenging for a patient with COPD. If you look on the back of one of the devices, you'll actually see the vents for air coming in. That air then that goes into your lungs, that pulls that with it. The vents are actually on the back ridge of that. I don't think it's in the picture very well. It's actually on the back of the device. And they're not very big. They're actually pretty small. So the air coming in and going into your lungs, there is a lot of resistance that exists there. So this is not an easy thing to use when you have difficulty with inhaling medications. The other thing that's really important to tell people about with the Advair device and with the Diskus is that you put a mouthpiece on something like this, you can do one of two things in that mouthpiece. You can suck in, or you can blow out. And one of the first patients I had as a resident put this thing in his mouth and blew. Created a beautiful cloud of white powder, poof, right in front of him. Okay, again, you give a device to people and you think, oh, there's no way that they can mess this up. Absolutely they are. And you know what the important part of that is? I had him there in the office and I was showing him how to use it. If he'd have gone home and done that, chances are he'd have just kept doing it and wondered why on earth he had more dust in his bathroom. Okay? We have them in the office, we have them there so we can see them use it. That's the best thing about samples for inhaled medications. I actually ask my drug reps to bring me more if for no other reason so we can show them, because there's not a patient who walks into my office that gets an inhaler that does not get showed how to use it, okay? Now, these devices are great. They do have limitations because of the amount of effort that's required. They also currently, the device itself will only hold 2 different medications, which is all it needed when it had Advair. We had an ICS and we had a LABA, right? Now we have 3 different classes of inhaled medications. So the device itself has gotten a little bit, I mean, it's still very, very useful, but there are other devices out there that have maybe a little bit of benefit in that area. All right, let's talk about the Handihaler. When Dr. Greider and I were going through, really the only 2 devices we had were the Diskus and the MDI, right? I mean, there was some other like really weird ones, like the pump one, and that were only there for a very short period of time. But when the Handihaler came out, this device brought with it a really interesting advancement in COPD management, and that was the introduction of a long-acting muscarinic antagonist in Spiriva. Now, we knew about muscarinic antagonists because we had ipratropium and we had Combivent. Combivent had come out, was in an MDI form. In a nebulized form, it was there as Duoneb, but Duoneb didn't come out actually for a little bit longer. Ipratropium was stable within the nebulized fluid. It didn't denature with the sound waves, and so it was able to be used in a nebulized form. But it was really short acting. Ipratropium does not have a very long half-life, and that's why you have to use it. If you're going to use ipratropium for chronic disease management, which we did, Combivent was actually never indicated for short-term use. It was never indicated for exacerbations. It still doesn't have that indication. The only indication for Combivent is for chronic COPD, or for chronic lung disease and COPD. It is 2 puffs 4 times a day, or 2 puffs Q6 hours. That's the indication. And you had to do that because of the short-acting nature of the albuterol and the ipratropium that was in it. Enter the scene, we get tiotropium. Tiotropium was the first long-acting muscarinic antagonist. The problem with it is that it was really unstable in any form other than a powder. Now, there were other devices that were out that had powders. Obviously, the Advair Diskus being one, and there were, like I said, there were a couple other powdered inhalers. But the Spiriva came in a little capsule, it came in a little pill, and this device that they developed to fit this in was really neat. I mean, we got it, we would play with it, you'd stick the pill in there, you'd open it up, you'd stick the pill in there, you'd shut it, you'd push 1, 2, 3, you know, nice, open it up again and breathe in. Right? What's more simple than that? Well, okay. Number 1, you could swallow the pill. Okay. Quite literally, they would get a box with a bunch of pills and this on top, this handy here. They would throw this away thinking that it was some form of advertising, and they would pop the pill. Okay, because that makes sense to them. Okay, number 2. Yes, you could forget to get rid of the previous pill. Let me stay in order here, because I have an order, Dr. Greider. I know, Dr. Greider was there with me when we were trying to, Dr. Greider was there with me when we were trying to teach people to do this initially, and it took time, because people were like, now hold on a second. Spiriva even came out with a video to show people, like they could download it. It came with a, this is before USBs, okay? They had a CD that you could download in your computer to play and show you exactly how to do the device. So one of the other innovations actually on Spiriva with time, because it did change, was when you push the button, now it pops the top. It didn't used to do that. People would push it and going, I don't know what it's doing. They'd push that button and be like, I'm not sure how I'm supposed to get the medicine. They'd open it up and they'd say, oh, here's the mouthpiece. And again, the idea of pushing a button and getting the medication is there. I push the button and I get the meds. I push the button and I get the meds. We would have to show them. The first inhaler also did not have a mesh. It had a different type of mesh to prevent the pill from coming back up. Because the pill, we know, is cellulose, which doesn't cause any problems in the lungs. But to a patient, it looks like plastic. And they were just sure they were breathing in plastic. So they would put the pill in there, and then they'd shut this, and they'd push it, and then they'd suck in, and they'd hear this little rattle. And then they'd forget to take the pill out, and they'd leave it in there. And so they'd open this back up and put the next pill in there. Time and time again. It didn't take very many pills before it got too full. And then by jamming them in there, they couldn't get them back out again. And so the device is essentially ruined. By taking, we have a device and we have pills, right? This is one of the biggest complications of this device. You have 2 different parts that have to come together in order to do it appropriately, okay? The other really hard thing about Spiriva Handihalers, because this is all education. You can teach a patient how to do this, but when you guys, what you need to think about when you ask a patient to do this is that when they breathe in through this device, it is very, very hard. This has the smallest chamber of any inhaled medication. And the vents that allow air to come in so they can move through the device and go into your lungs are the smallest. Actually, it's right here on the edge of the device. That's where the air comes in. Air comes in, gets rattled around in here, and then comes out into you. Very, very hard to use. that's a problem, because if you're going to rely on this medication to treat your patient, you need to know that they're getting the medication, okay? Now, Handihalers, though, brought with them Spiriva, and Spiriva revolutionized the way we took care of COPD. It was a new medication class. It certainly gave us a lot more options for treatment. We didn't know about safety, but I don't know, how many journal clubs did we have in a row that we looked at Spiriva? Like 20, because it was one of the most studied medications for several years. Okay, now, one of the newer devices that came out as a result of, I think, some of the things that we're dealing with. Again, as new devices come out, the goal is to create a device that meets the needs of patients, but is also different enough that it gives you a patent and gives you a direction to go. When we had the Diskus, and we had the MDIs, and we had the Spiriva inhaler, another device came out, which was Tudorza. If you haven't seen Tudorza, it's another handheld device. It got rid of the pill, because it's another long-acting muscarinic antagonist. It got rid of the pill, and it had several positive things. One, it had a button that you would push to activate the medication, and you actually had a visual, and then you had an auditory, a click when you actually took the medicine appropriately. So you could know, hey, I got enough inspiratory effort. Hey, I know I've got the medication. There were a lot of neat things about it. Unfortunately, I think it came out at the wrong time. If it had come out a few years earlier, I think it would have been a much more mainstay. But these other devices came out and kind of took over. And that's, the Respimat was one of them. What happened before the Respimat device came out was a big change in how we prescribe medications. These devices were coming out, these newer medications, combinations of medications were coming out. And we were struggling because a lot of people were having difficulty with generating enough inspiratory effort. Remember, with all the devices we've talked about, besides MDI, they had to have sufficient inspiratory effort in order to actually activate the medication and to get the medication. The MDIs had all sorts of problems in that you had to have the appropriate strength. If you had a lady with rheumatoid arthritis, she's using both of her hands to try to push down at the same time breathing in, the timing aspect of it. So what solved that for us was a class of medications that came out via nebulizer. And that came out in 2007, I believe, was long-acting beta agonists in a nebulized form. We had inhaled corticosteroids via nebulizer in the form of budesonide, and we'd had that for years because it was used for asthma and it was used in kids. As a matter of fact, Pulmicort was only in pediatric respules. With the idea of using that in adults was not really mainstay back in 2007. Now we do it all the time. Well, Brovana was the first long-acting beta agonist to come out in mass production and be used in the United States, followed very closely by Performist. So we now have two nebulized long-acting beta agonists. Well, we were using Advair, which was an inhaled corticosteroid and long-acting beta agonist for the treatment of COPD patients. And because of the way that was billed through Medicare, we could actually get nebulized medications for patients cheaper for them than we could other devices. And as long as we showed that they couldn't use the handheld devices because of inspiratory effort or because of timing issues, we could get them Brovana and budesonide via nebulizers that they would do twice a day. The benefit there was that there was no respiratory effort required by the patient. But it is very, very costly to the government. And as a result of that, a lot of these handheld devices were not used as much. The Respimat device was really an answer to that. Now, for those of you who are not familiar with the Respimat device is made up of three parts. There's a canister that actually contains the medication, and when you get this medication out of a box, the canister is free floating, okay? That canister then gets put into the major device, and has to be pushed in against a table. Now, for those of you guys who are watching, I'm sorry you can't see this, but I'm putting the canister into the device and pushing it down. You then have a cover that you have to put on. And the reason for that is to protect it, the canister, from the environment. Now, after that's all put together, you simply turn, push, turn, push, turn, push, and now you actually get your medication. All right? Simple enough. Again, how many different ways can we screw this up? There's lots of different ways. Putting it together becomes a challenge. You don't want to take the cap off and turn, because if you're pushing the button when you turn, you release the medication and it gets all over your hand. If you turn and let go, medication comes out. This isn't a good one because it's empty. But if you turn it and let go, medication actually comes out. Okay? But if you turn, that activates the button. So the device itself does create some difficulties, but it helps with the amount of respiratory effort that's needed. This is essentially an MDI that is released slowly. The company who came out with this first started it with Combivent. Remember Combivent's, that combination of ipratropium and albuterol? First came out with the Combivent. And what they found was that patients actually were able to do this if they were able to do a nebulizer. The company now has the ability to say that this is a nebulizer-like medication. The government loves that, because guess what? Show me that you can't use a Respimat inhaler before you can get your nebulized medications, right? Because this is now in any class. As a matter of fact, I have a patient who is in a hospital. Her insurance company will not cover her nebulized medications because she can do a Respimat. That's okay. I don't care, as long as she's getting her meds, right? So the one thing, though, that you have to take into consideration, and you might not immediately think about it, is you have to go back. Remember, a lot of our patients are older. They've gone through this history, right? They've taken all these different types of medications. A lot of them have used this. With this medication, this is an MDI. How do we take this? You have to start breathing before. You have to inhale before you activate the medication. With the Respimat, it's the complete opposite. Because this medication comes out over the course of 3 seconds, you have to activate the medicine before you start breathing in. Otherwise, most patients will run out of inspiratory flow before the medication is completed. You would never think about that in talking to a patient unless you thought about all these other different devices and where this patient is coming from. That's where the health literacy component comes into this again. We have to think about the things that these devices do and don't do. Now we're running out of time, so I want to talk about this last one. I have a slight love relationship with this device. I love it. If you want to know all the things I love about the Ellipta device, please come talk to me. But this is like an engineering marvel to me. This device took everything that was bad about every other device and fixed it. The other thing that this device has is it has 4 different chambers in it, meaning it can actually contain 4 different meds. Currently, if you're keeping track, we only have 3 inhaled medications. This company went so far as to make sure that they had enough room for the next medication that came out, because there'll be something someday, right? But right now, this is what the Trelegy device is in. The benefits here, the fact that it has a top that opens on its own, the fact that it's once a day. The vents going in are huge. The hole that they have to suck through is very large. The flow of air through this device is the easiest by far, by massive degree, than some of the other devices. Once it's closed, it's advanced. The counter on it is the single largest counter on any device in the medical field. Okay? If you compare that counter to this one, you might be able to actually read the front of this one versus this one. Okay, again, I have a slight obsession with this device. So, advantages, nebulizers, pressured MDIs, DPIs, they all have their advantages and they all have their disadvantages. But ultimately, it comes down to, can you explain to a patient how to use it? have a spiel, have something that you talk about. I talk about blowing into these devices versus sucking in. The patients all laugh, but the reality is for the one person that I say that to that was like, oh, wait, that's what I was gonna do. Oh, ha, 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 Dr. Hardee, what kind of an idiot would do that? That helps. And you have to be able to communicate that with a patient. Otherwise, how do you know if they're getting their meds, right? Among older patients with asthma, interventions to promote proper medication use could simplify task and patient roles to overcome cognitive load and suboptimal performance in self-care. What this study actually showed was that most patients in the nursing home that were asked to do devices on their own did them improperly and did not get the medications that their physicians felt that they were actually getting. The reality was they needed to be coached. And it needed to be simplified, which is why these devices become so much more important as time goes on. All right, any questions? I love this. This is actually an asthma inhaler. I found a picture of a guy using one. You put your mouth over the face mask and you breathe in. How cool is that? Darth Vader making asthma scary since 1977. Okay. What questions do you guys have for me? All right. Thank you very much. If you want to see all my references, more power to you.